Hello and welcome. I'm Dr. David Minter. I'm going to be assisting you today with your critical thinking for your IM 660 course. Today we're going to be looking at a case of acute ischemic stroke. We're going to be talking about some stroke mimics. We're going to talk about how to use history and physical exam to clinically decide if you think the patient's having a stroke. We're going to talk about the acute workup for stroke and then the acute treatment for stroke under various clinical conditions. We're going to talk about the subacute or hospital workup and then how we can use that to prevent stroke in the future. There's going to be a practice question that's going to immediately precede the actual case, and then after the case, there'll be an answer and an explanation. So without further ado, let's get started.
A 67-year-old male with a history of hypertension, type 2 diabetes, dyslipidemia, and atrial fibrillation presents to the emergency department with sudden onset right-sided weakness, facial droop, and difficulty speaking. Symptoms began 1.5 hours prior to arrival. His vital signs are BP 200/110, HR 88, irregular, R 18 breaths minute, and SpO 296% on room air. Neurological examination reveals non-fluent aphasia, right-sided hemiparesis, right-sided facial droop, and a left gaze preference. CT head shows no acute hemorrhage. CT angiography reveals an occlusion of the left middle cerebral artery. Which of the following is the most appropriate next step in management? A. Initiate intravenous TPA. B. Administer aspirin 325 mg orally. C. Perform mechanical thrombectomy. D. Administer 4-labetalol to lower blood pressure. E. Begin anticoagulation with a direct oral anticoagulant, DOAC.
Chief complaint is of sudden onset right-sided weakness. Patient is a 67-year-old male who was home eating breakfast when he suddenly dropped his fork and noticed he couldn't move his right arm. His wife reports he became confused with slurred speech and his face appeared droopy on the right side. Symptoms started approximately 1 hour prior to arrival in the ED. The patient has no headache, vision changes, or seizure activity. The patient has a past medical history of hypertension, type 2 diabetes, dyslipidemia, and obstructive sleep apnea. Surgical history is positive for appendectomy and cataract. Patient smokes, has 20-pack year history, drinks 1 to 2 drinks weekly, and has no illicit drug abuse. Family history is positive for dementia, coronary artery disease at 65 in his brother. His current medications are metformin 1,000 mg BID, lisinopril 10 mg daily, and atorvastatin 20 mg daily. Vital signs for this patient show a blood pressure of 198/96, heart rate of 88, respirations 18, an O2 sat of 96% on room air, and a temperature of 98.6. The patient's alert but unable to follow complex commands. His ENT exam's normal, has moist mucosa. Cardiovascular exam shows normal rate and regular rhythm. Respirations are clear to auscultation bilaterally, abdomen soft, non-tender, non-distended, positive bowel sounds, no palpable masses or hepatomegaly. The neurological exam shows difficulty speaking and right-sided weakness and sensation deficits. His extremities have no edema and +2 pulses bilaterally. So when considering a differential diagnosis for this patient, given the fact that he's presented within 1 hour, this completely changes how fast things need to happen because he would be eligible for TPA. Your differential diagnosis should always consider, is this patient having a stroke? So this is something that needs to be decided quickly as time is brain tissue in receiving TPA. About 25% of patients that present with stroke-like symptoms have what's called as a stroke, or what's known as a stroke mimic, which would be things like seizures or hypoglycemia, infection, metabolic disturbances. Picture a 75-year-old woman from a nursing home who was slurring her speech in the morning, so the nursing home sent her in. Well, maybe they just noticed this for the first time in the morning, and she actually has hypernatremia with a sodium of 165 because she hasn't been drinking water all day. So physical exam findings in these type of patients may show less focal neurological deficits, more globalized weakness, gradual mentation changes. The patient that we just outlined seemed to have a very sudden onset focal neurological change. For example, somebody who immediately drops to one side and falls down and is unable to move their arm and leg has acute onset hemiparesis, as opposed to somebody, let's say, that had ascending paralysis over several days, also resulting in leg weakness, arm weakness, and then also facial weakness. That may be somebody that had GBS, especially if it was symmetric versus asymmetric. When confronted with focal neurological deficits, you want to also try to decide, is this a stroke, by categorizing them into a stroke syndrome. Familiarity with these different stroke syndromes will make it easier to judge if you believe your patient to be having an acute stroke. Starting with middle cerebral artery strokes, these tend to have weakness on the contralateral face and arm greater than the leg. Same with sensory changes. Sometimes they look toward the lesion, and depending on where the infarct is, if it's on the left side, which is the dominant side in most patients, they might have an aphasia, Broca's versus Wernicke's. Broca's meaning broken words. They start and stop sentences. They can hear the fact that they're doing something wrong and they're saying the wrong words, and it usually is very frustrating for the patient, as opposed to Wernicke's and aphasia, which is more of a word salad, where the patient's fluently speaking to you, but not making any sense. If it affected the non-dominant side, the patient may have neglect on that side of the body. Anterior cerebral infarcts have weakness and sensory changes on the contralateral side of the body, but it's the leg greater than the arm now, and the face is spared. They may have mentation changes, specifically related to frontal lobe involvement. They may have apathy as well as disinhibition. Abulia, which is inability to make decisions. They might have more primitive frontal lobe reflexes like a baby would, like grasping and sucking. They'll also have incontinence. Posterior cerebral artery infarcts are difficult to diagnose. There's multiple different syndromes associated with this. So without going into each one of those specifically, I just want to outline some general features about posterior strokes. They'll have cranial nerve symptoms, things like the 5Ds, dizziness, diplopia, dysarthria, dysphagia, disequilibrium, also things like ataxia and visual field deficits. Besides these cranial nerve symptoms, they may have acute crossed deficits, meaning that they'll have cranial nerve findings on one side of the body and then sensory or motor problems on the opposite side of the body. Depending on exactly where this is happening in the brainstem or cerebellum, patients can just have ataxia. They can also have some of those weirder syndromes you may have heard of, about things like locked-in syndrome, if the bilateral pons are affected. The last syndrome you should be familiar with is lacunar infarcts. So this is a deeper area of the brain. They have little tiny lenticulostriate arteries that branch off of the middle cerebral artery that feed these areas. So lacunar infarcts, because these are tiny little arteries inside of your brain, they're more subject to vascular disease from things like uncontrolled hypertension. They may present with pure motor or pure sensory deficits. You may have pure ataxic features. Dysarthria and clumsy hands may indicate a pons or internal capsule stroke. And then, depending on if it affects both areas, you may have mixed motor and sensory deficits contralateral to the body. So what other history should we ask about on our patient? Well, in this circumstance, if they presented to the emergency room with a stroke an hour ago, I'm going to be asking them questions related to, is this a stroke or not? So does the patient have a fever? Did they just fall and have a head injury? Do they have history of seizure disorders? Have they have something similar like this present? That mixed with my physical exam would make me lock on to, is this an acute stroke or not? The rest of my pathomedical history I would focus on, if I believed it to be a stroke, would be regarding indications and contraindications for thrombolysis. So what do we make of our physical exam? What other things should we be looking for? Well, again, if this is an acute stroke, the main thing I'm going to be focusing on, if the patient's been here less than 4.5 hours, is this a stroke? Using the physical exam cues listed for stroke syndromes as I previously had listed. And if it's only been that limited amount of time, I need to do a focused neurological assessment known as an NIH stroke scale. This has a shortcut form. It's got 11 points on it to quickly do a neurological exam and then grade the person as having a minimally disabling stroke versus a highly disabling stroke. Additionally, I may want to do a physical exam focusing on things that can cause stroke. Perhaps the patient has carotid bruit, Maybe the person has an irregular heart rate, which would make me think atrial fibrillation, or maybe physical exam signs like murmurs, Janeway lesions, things that would make me think the patient has endocarditis. So breaking down our physical exam a little bit more, uh, using the NIH stroke scale, we see the patient has unable to answer questions about month and age, as well as unable to follow commands, meaning he gets 4 points for level of consciousness. He has no gaze problems or visual field deficits, but his facial palsy is moderate to severe, giving him 2 points. His motor deficits in his right upper extremity give him a 4 point, and motor leg in the lower extremity on the right side gives him 3 points. Again, upper extremity greater than lower extremities and facial weakness are all consistent with MCA infarcts. He speaks unintelligibly, giving him 3 points for language, 2 for dysarthria, and he has no extinction or inattention. So we get a grand total of 18 for his NIH stroke scale. Now that we're pretty sure this patient's having an acute stroke, we want to focus on our workup. This begins with imaging in patients. I would order a CT of the head without contrast. The main point of a CAT scan is not to diagnose the stroke acutely, but we're trying to rule out a hemorrhagic stroke. Ischemic strokes are better seen on MRI and does not need to be diagnosed acutely. I would also order a CT angiogram of the head and neck, looking for large vessel occlusion. I'm not going to order things initially like CT perfusion imaging. This can help decide if an area is ischemic, but if that ischemic area is completely infarcted versus there being a penumbra or salvageable area. I'm also not going to order an MRI acutely because the point of my CAT scan is to rule out hemorrhage for the possibility of TPA and do a large vessel evaluation for the possibility of sending the patient for a thrombectomy. After imaging, I would probably do some lab work. I would order things like a glucose, a basic metabolic panel, a CBC, and coags. The main thing I'm looking for on lab work is contraindications for TPA that I would be ordering acutely or possible stroke mimics. So things like hypoglycemia would be a stroke mimic, or if the patient's blood sugar was 800. Maybe if I was iffy about my physical exam, maybe this is just a person presenting with HHS rather than an acute infarct. My basic metabolic panel will show sodium changes, which can also be common stroke mimics, both in hyponatremia and hypernatremia. Uremia, to a significant degree, can cause weakness and can cause mentation changes. On a complete blood count, I would look for things like polycythemia or hyperleukocytosis, since this causes sludging of the blood and can be a cause of strokes. And things like thrombocytopenia being less than 100,000 can be a contraindication for TPA. Coags are more important in a patient that's on anticoagulation, things like warfarin, when I can judge if their INR is greater than 1.7, because that's a contraindication for TPA. Other things like liver disease may also be a contraindication if their INR is greater than 1.7. So what acute treatment should I start on this patient? Well, I've been alluding to the idea of giving TPA to this patient. So to be confident about this, I would have to know some of the indications and contraindications. Indications for TPA include a diagnosis of ischemic stroke causing measurable neurological deficit. Generally, this means having an NIH greater than 5 as being a disabling stroke. Now, there's some wiggle room in this. So the more points you have on an NIH scale, obviously, the more debilitating a stroke's going to be. But you don't get very many points for aphasia. You get 1 or 2 for aphasia, but now that would mean the patient would be unable to communicate for the rest of their life. Or maybe they're a violinist and now they've got right upper extremity weakness, giving them an NIH of 1, but now their career is ruined. So they use this 0 to 5 scale for NIH as being minor disabling strokes, but you have to also place that in context of your patient. Another indication includes the onset of stroke symptoms being less than 3 to 4.5 hours, and then an age greater than 18. So if I want to give TPA to a patient, I'm going to need to ask them some specific questions, as I mentioned earlier, regarding contraindications to TPA. Exclusion criteria includes things like recent head trauma in the last 3 months, history of brain bleeds in the past, brain cancer, or GI cancers, internal bleeding or gastro bleeding in the last 21 days, if they have signs and symptoms of dissection, meaning they're also having tearing chest pain along with their new neurological deficits, or if they have history of aneurysms. I should also talk to them about bleeding problems. So is this a patient I suspect of having a platelets less than 100,000? So maybe they have CLL, maybe they're on chemotherapy. Are they taking any medications for anticoagulation, such as warfarin or possibly NOACs? There are some exclusion criteria that are correctable, things like hypertension and hypoglycemia. Hypoglycemia is a common stroke mimic, so if found, meaning a blood glucose of less than 50, this should be corrected rapidly and the patient should be evaluated for neurological change. Hypothetically, if they return to baseline after their glucose was replaced, then this would mean that the patient had a stroke mimic, not an acute stroke. Blood pressure is another contraindication that can be corrected. A systolic of greater than 185 or diastolic greater than 110 in a patient that qualifies for TPA can be corrected. So we could give the patient 10 milligrams or 20 milligrams of labetalol and see if their blood pressure improves. If we can lower it to less than 180 over 105, then we could still push the TPA on the patient. There's some additional 3 to 4.5 hour window exclusion criteria, such as the use of all anticoagulants regardless of the INR, as well as if the patient has a very severe stroke, meaning an NIH greater than 25. These large areas of stroke are more fragile and more subject to hemorrhagic conversion. There are multiple other relative contraindications. Different hospital protocols may raise or lower the relative exclusion. If you think of a relative exclusion, then this is something that should be discussed with the patient to see if the benefit of TPA is still worth it to them. After administering TPA, the patient needs to be monitored quite extensively. The TPA is given as an initial bolus and then infused slowly over 60 minutes. The patient should be monitored and the infusion should be stopped during that hour if the patient develops any severe neurological change, meaning maybe their right-sided hemiparesis, now they're bilateral, or maybe they've lost consciousness, if they're complaining of nausea, vomiting, severe headache. These would be a sign that they've converted from an ischemic to hemorrhagic stroke, or if their hypertension becomes unmanaged, meaning that it's outside of the safe zone to give TPA. So what is the benefit of TPA? If TPA is administered, then the patient is 30% more likely to have minimal or no disabling symptoms at 3 months post-stroke. What is the risk of TPA? The patient's at risk for ischemic to hemorrhagic conversion at a rate of about 6%, and angioedema, which is rare, at a rate of about 1%. If angioedema occurs, they should be treated standardly, like anaphylaxis, with IV methylprednisolone, antihistamines such as diphenhydramine, Pepcid, also epinephrine, depending on the severity of angioedema. Intracranial hemorrhage is treated with IV cryoprecipitate as well as TXA. So when overall looking at the risks and benefits of patients, there's a nice visual representation of this. So this is 100 patients. You can see the dark green has normal or near normal after the 3 months. The light green is better, but the majority of patients have no change with TPA, and then the few minority patients actually have worse or possibly died from the administration of TPA. So what about thrombectomy for a patient? So these are complicated guidelines. In the module, I outlined some of the most recent guidelines, which have different class 1, class 2 benefits. You don't have to have any of this memorized. This is why neurointerventional exists, to discuss these cases with you and see if the patient would be a candidate. What neurointerventional does is they'll look through the patient's scan, talk to you about what the patient's symptoms are, and then see if they would be a candidate for clot retrieval. This can be done in addition to TPA, so hypothetically, a patient could have both of these things done and should have them both done if they qualify. So in our case, let's say that they're not a candidate for clot retrieval or thrombectomy. So these patients would need to go to the ICU for further blood pressure control with a blood pressure goal of less than 180 over 105. We would also want to avoid placing any additional catheters on them, such as Foley catheters, arterial lines, since they just had that clot-busting drug administered. So we just want to decrease any chance of them having significant bleeding. They would need further imaging done, like a CT or an MRI the next day, to rule out the idea of conversion to hemorrhagic stroke prior to starting any aspirin. But let's say hypothetically this patient came in 6 hours after the onset, then what would change rather than the 1 hour that they came in at? They would no longer be a TPA candidate. but we would still talk to neurointerventional as their guidelines have the possibility of thrombectomy, which can be done up to 24 hours. So we'd still reach out to them to see if they're a candidate. Also, in that patient, we wouldn't need to intervene on their blood pressure. So our patient had a blood pressure of 198/96. So that's if they're not a TPA candidate any longer, then the blood pressure guidelines change for them. So for a patient that's a non-TPA candidate, we don't need to intervene on their blood pressure unless it's greater than 220/120, or they have some additional medical condition that would benefit from lower blood pressure. So hypothetically, what does that look like? So let's say their blood pressure is 200/100, and they start having crushing chest pain along with this. Well, fine, I guess then we'll lower your blood pressure a little bit, or if they started having decompensated heart failure because their blood pressure is running so high. So the goal is that they need permissive hypertension. The ischemic area in the brain thinks it's not receiving enough blood flow. So the body's natural response to this is to increase blood flow to the brain, meaning that there's an acute window of hypertension for a patient. This is a natural response. However, they've found that patients over 120 tend to fall off the autoregulation curve for this, and the hypertension tends to worsen the ischemia. So what subacute workup should we order? Or in other words, what type of workup should we do to help decrease the chance of stroke in the future? The first thing we need to do is diagnose that a stroke occurred, and this is done by diffusion-weighted MRI of the brain. The CAT scan that we did initially is to rule out hemorrhagic as a cause for stroke, and the CT angiography is to see if the patient's a thrombectomy candidate. The CT angiography, if done acutely in an emergency room, can help decide risk stratification later to see if there's any carotid disease. So if a patient hypothetically had carotid stenosis on CTA that was greater than 70% on the ipsilateral side that the stroke occurred, then they would benefit from carotid endarterectomy to decrease the chance of stroke in the future. If they did not get a CTA in the emergency room, meaning that they came in greater than 24 hours after the stroke, they may benefit from having a carotid Doppler done, which can give you the same image, can give you the same information about carotid obstruction, doesn't involve radiation, doesn't involve any contrast administration, and is a lot cheaper of a test. We would need to do an EKG on this patient, as well as probably keep them on telemetry, the goal of which is to try to diagnose underlying undiagnosed atrial fibrillation, as this can be a cause of cardioembolic strokes. If found, depending on the characteristics of the stroke, the patient may be started on anticoagulation in less than 2 weeks from when the stroke occurred. Certain high-risk patients, like if your blood pressure is wildly uncontrolled or if it was a huge area of your brain, then they recommend starting anticoagulation at greater than 2 weeks. Again, the goal being to decrease the chance of hemorrhagic transformation. In practice, this seems to be kind of left up to the neurologist looking through the scans and then looking over the patient's chart. We would need to order a 2D echocardiogram with PFO study. Besides looking for a PFO, we would be looking for thrombosis and aneurysm. These are all indications for anticoagulation to prevent stroke. We may find endocarditis on a patient, which can be a cryptogenic cause of stroke. This would totally change the workup and what we're doing for them. They would need blood cultures. They would need 6 weeks of IV antibiotics. But focusing on a PFO for a second. These are incredibly common things. About 25% of the population has PFOs. So they have come up with guidelines about patients that may benefit from closure. So PFO closure is done in patients that are 18 to 60 years of age. The stroke has to be non-lacunar. Lacunar infarcts are not cardioembolic. They tend to be caused by hypertension, as I stated earlier. But deciding if it should be closed or not is kind of talking to the patient in a multidisciplinary setting where cardiology and neurology all kind of weighs in if they think they would benefit from this. And this is an outpatient procedure that's done, and it's based on the characteristics of the PFO. And then some high risk features would be if the patient had had multiple strokes despite being on antiplatelet therapy. As far as lab work goes for the patient, we would probably do a lipid panel since we're starting them on statin therapy to prevent stroke in the future. Our patients, diabetics, we would probably check an A1C to talk to them about getting their blood sugars better under control to decrease the chance of stroke in the future. So what chronic treatment should we start in this patient? This would be the treatment that helps decrease the chance of stroke in the future. Well, we'd want to start the patient on an antiplatelet drug. This generally involves aspirin. Clopidogrel is also an option. In combination, they don't have any increased synergy together, but they do have increased chance of significant bleeding if used in combination long term. So generally, you can use either one of these to start with a patient that's antiplatelet medication naive. Aspirin's cheaper. Clopidogrel, if the patient has an aspirin allergy, would be an additional benefit. There is a guideline that came out in 2014 that says if the patient the patient would benefit from both of these within 24 hours of a minor ischemic stroke for a continuation of 90 days. So long term, they're not combined. Short term, they can be combined. If the patient's naive of both, generally they just get started on one. A statin should be started on all patients, regardless of the patient's LDL. We should focus on hypertension control. Long term, this would be a blood pressure of less than 140 and diastolic less than 90. For lacunar infarcts, since these are hypertension driven, we should shoot for a systolic blood pressure of less than 130. The patient should have physical therapy, occupational therapy, speech therapy, depending if they have any aphasia or difficulty swallowing. The patient should also probably have a physical medicine rehabilitation consultation to see if they would benefit from more intensive therapy, as patients have been shown to improve from their deficits the earlier high intensive therapy is started. The patient should also have some lifestyle modifications, meaning diet change to things like fruit and vegetables, low-fat dairy products. They should stop smoking because that's easy to tell people, hard to actually turn into a reality. They should decrease alcohol intake as well as imbibe and increase exercise. So let's wrap up our case. The patient received TPA, was monitored in the ICU for about 24 hours. They had a diffusion-weighted MRI showing a left MCA infarct. After that was done, showing no hemorrhagic conversion, they were started on aspirin therapy. CTA that was done showed less than 50% stenosis bilaterally, so they're not a carotid endarterectomy candidate. They had a benign echocardiogram not showing a PFO or any other significant disease that would change management. The patient had physical therapy evaluation, occupational therapy, was deemed a good candidate for inpatient rehab by physical medicine and rehabilitation. The patient was rounded on multiple times in the hospital, monitoring the patient for complications of stroke, things like are they developing a fever? Are they having dysuria? Are they having cough with sputum production as UTIs and pneumonia? Infection overall is common in the post stroke period. The patient was started on DVT prophylaxis. As the patient is hemiparetic, they're going to be at an increased risk of developing thrombosis. And then we would want to monitor the patient for any further neurological decline, meaning hemorrhagic conversion or possible additional stroke. The patient was discharged to inpatient rehab and then discharged home for physical therapy outpatient, as well as follow-up with neurology and primary care physician.
Correct answer. D. Administer intravenous labetalol to lower blood pressure before considering TPA. This patient presents with an acute ischemic stroke in the left middle cerebral artery (MCA) territory and is within the 4.5-hour window for intravenous thrombolysis. However, his blood pressure is above the threshold of 185/110 mmHg for TPA administration. 4 labetalol or another antihypertensive agent should be used to reduce blood pressure below this threshold. Choice D. After blood pressure is controlled, TPA may be considered if no other contraindications exist. Mechanical thrombectomy, choice C, can also be pursued if imaging confirms large vessel occlusion, but thrombolysis should not be delayed if the patient qualifies. Aspirin, choice B, and anticoagulation, choice E, are not appropriate in the acute phase.